Hello, my friends. Welcome to the Systema Health podcast. I am your host, Andrew Kornfeld. I am so excited for you to be here and to hear systems-based perspectives in inflammatory bowel disease and broader health conditions, and anyone who is interested in just expanding their health span, in understanding chronic disease, and really understanding that there are other and new approaches to chronic illness that involves collaborations between both people practicing integrative practices and the mainstream. Today's guest is Dr. Samir Kakodkar. Samir is a renowned gastroenterologist based out of the Chicago area, and he did his training at Northwestern in addition to some very advanced trainings, specifically in inflammatory bowel disease. Both Samir and I have inflammatory bowel disease, and we work professionally with patients and individuals with inflammatory bowel disease like Crohn's disease and ulcerative colitis. You will be hard-pressed to find two other people who care more about this condition, who understand this at both a professional and personal level. And you will hear things in this podcast that you will hear nowhere else. And I am so excited for you to listen. Just as a quick reminder, I do not necessarily endorse everything that Samir Kakodkar says in this podcast, and he does not necessarily endorse everything I say, but we both have very unique perspectives and bring incredible knowledge and depth to the conversation. Without further ado, I am presenting Dr. Samir Kakodkar. Welcome everyone to the first episode of the Systema Health podcast and a special reboot of the Against the Grain podcast with the one and only Dr. Samir Kakodkar, an incredible gastroenterologist located in the Chicago suburbs. Samir, welcome.
Andrew, it's good to be here again. This is our third round of the podcast. We did two prior. I think it's been 5 years, right, since the last one. So
5 years since the last one, and 7 years since the first one. And we agreed to do it every 2 years, but we waited 5 between the last one, at least 4.
right, yeah, I took a little bit of a break from the podcast. Got really busy with my practice and some family stuff. So yeah, I'm open to kind of rebooting it with this episode as kind of a collaborative effort here, and I know you're going to start your own too. So, yeah, let's do it.
Yeah, that first episode was with Dr. Lucy Mailing. She was, also located in the Midwest in Chicago there, and we were at your hospital at that time. And then the second one was with one of my co-founders of IBD Coach at the time, and it was both were very, very interesting episodes. I got a lot of feedback from people all over the internet, after both of those episodes. So
Cool. Okay.
yeah.
So
Well,
yeah, I'm excited. I've been interviewing people for a few years. Nobody ever reached out to me to interview me, so that's why I wanted to do this. I've definitely learned a lot. I think the difference between myself now compared to that last episode I did on my podcast is I've just been in the trenches. I've been in clinic. Now my practice is probably 70-80% IBD. I'm seeing like almost all IBD in my office. And the things I've seen, scoping these patients, seeing the response to different kinds of therapies, and I do feel like I see a lot of people that were like us, that are like us, that are curious about alternative therapies besides kind of the standard of care, the medications, what else is out there. And that's kind of how my journey started too, doing deep dives on things. And it's like a different era now. I think in our era, when both of us were diagnosed, probably when were you diagnosed? I was diagnosed in 2000, I believe 2008.
I was
So
2006.
okay, so similar era, around that time when you were looking outside of the mainstream, there were only like a few things. The internet, you'd go on the internet, you knew about the specific carbohydrate diet, you knew about certain other things like the Maker's diet. There was another diet called the Life Without Bread diet around in those days.
Wow.
And also there was like Ginny Patel Thompson.
Mhm.
She was like one of these gurus who I interviewed on my podcast, who was like about all these alternative therapies. So there were kind of lanes that you could go into, but now it's like a completely new era. I've got patients coming in to me in clinic who are referencing people I have not even heard of,
Wow.
different kinds of diets, different kinds of protocols. I know you're in that sphere too. So yeah, I'm curious to see also
I
what you've
mean,
got
one
going
thing that
on.
I would just say is what I find when I talk to IBD patients is 98 to 99% of IBD patients, they pursue mainstream medicine, they have a gastroenterologist, and they are also interested in lifestyle right there. And yet in your world and in my world, it's rare that the two of us cross. For me, I feel that we sort of invented the field of IBD coaching. And to this day, I am still the only IBD coach out there that I know that talks to gastroenterologists daily, that asks patients to make sure they're getting, their fecal calprotectin checked, to make sure that they are, what I mean, that we are in collaboration. So I think that, the fact that that both of us have IBD, number one, and that you are, interested in, we can call it alternative therapies or just lifestyle therapies in general for IBD. And that as a coach from my world, there's almost a completely separate world from gastroenterology, just mainstream medicine in general. That says something. And I think that this is what IBD patients want is they want to understand both. They want to know what the safest treatments are out there. They want to know what are evidence-based lifestyle interventions that are based in reality, not based in things that just random people think that don't actually work.
Sure. Sure.
Yeah.
Yeah, no, that is something that is unique from your perspective, is kind of melding kind of the both worlds. So, but yeah, I'm appreciative of that. And, I also work with a lot of patients who work with other, in other spheres or working with other kind of alternative practitioners. Some of the people I've interviewed over the past, and I'm always open to that, within reason. But again, just like what you just mentioned, I am somebody who tries to be evidence based, but understanding the limitations of evidence, right? You can't really study a lot of these things with randomized controlled trials, which is the gold standard to really prove something works. So yeah, I do have a lot of people coming into my office who find something on the internet and say, "Oh, is this worth taking? Is this worth taking?" And I have certain thoughts on some of these sometimes supplements, herbal treatments, but yeah, it's very hard to study these things, to get the funding to study these things. Usually the big pharma companies, they have the money, the backing to actually study their interventions, and they are effective therapies, no doubt. I've seen over the years that, and there's some nuance to how to make medications work better for people. And I think the people like how I started out, where I was very skeptical about medicines and I was terrified of them and actually did not want to take them and went periods of time without taking them. Um, I think that attitude actually does more harm than good, as far as delaying therapy and starting it later and being on courses of prednisone for years and years and just kicking the can down the road. There's so many people I've seen in my office like that where they have been on intermittent courses of prednisone for years and are just so terrified of these medicines to the point that they have a blind spot about what the chronic damage they're doing to their health by leaving IBD suboptimally treated.
I couldn't agree more. And, I think there is a role for individuals like me, as rare as we are, to actually, reduce that friction between patients actually accessing medical care with gastroenterologists who are terrified of gastroenterologists. They're terrified of getting a scope. They're terrified of these things. And I have several, members that have come into our program that didn't have a gastroenterologist before they started with me, and they are now happy with their gastroenterologist and their medical care, in addition to all of the quote, alternative things that they're doing. But listen, Samir, I want to ask you the first. I have a bunch of questions to ask you, and the first one I just want to ask you is, what in the last 5 years since we last talked, what has been your biggest perspective shift in terms of the world of IBD, and what do you see? What do you see changing?
It's actually, I've had kind of the way I practice IBD, and seeing patients with IBD, it's almost been validated over the years where I didn't have a lot of the high quality research to support exactly everything I was doing. But but now all of the lines of research are kind of supporting what I was saying, years ago. I remember I had done a talk through the Specific Carbohydrate Diet Association several years ago. It used to be online, but not anymore, where I talked about how the medications that are used for IBD only address one aspect of what's going on. Basically this dysregulated immune system. But if you don't address the other side, which is the environment of the gut, on the other side of the lumen, what's happening with the gut epithelial cells, the microbiome, that it's a false sense of security. Even if the medicines work, over time you are at risk of losing response, flaring, if you don't basically address the gut environment. And there was a study just recently published that pretty much validated that whole perspective. They compared large amounts of patients who, like, they had one group of patients who had Crohn's disease, who were relatively newly diagnosed, who had never been on any biologics. The second group was a group of patients with Crohn's who were in remission on biologics, mostly anti-TNFs, but there were other patients also on smaller amounts of patients on anti-integrins or anti-L23s, 1223s. And then the third group, which was just normal controls, people who didn't have IBD, who were, relatively healthy. And what they found is that actually, when they did these very careful analyses of their microbiome, something called transcriptomics, which is
Hmm.
the analysis done on ileal biopsies, and metabolomics, and just checking really everything you can think of, very careful dietary surveys that were done. They found that the people who were in remission on medication, on biologics, their gut environment was similar to people who are newly diagnosed. So it doesn't seem like the biologics are really fixing the microbiome or really improving things. And what they found is that the epithelial cells of the gut in people who are in remission on biologics, even if they have a colonoscopy and it looks like mucosal healing, it looks healed up, but actually those epithelial cells are screaming out. They're still saying, hey, like, we're trying to protect ourselves from something going from this gut environment, and they are pouring out some, hydrogen peroxide. They produce their own hydrogen peroxide to try to defend itself from things in the gut, and also producing a lot of more mucus as this kind of plea to, like, they're trying to save themselves. So the medicines, yeah, they make things look normal with the camera, but if you do deep dive analysis, actual, like the study did, it seems like it's a false sense of security. You got to address the other side of it. And what they found is that people who are on a Mediterranean diet, as opposed to eating ultra processed foods, which I've been harping on forever, ultra processed foods actively, independently thin that mucus barrier that usually protects the epithelial cells, independent of anything. It has a direct effect on that, and that kind of messes up your security force to prevent the microbes in your gut from stimulating the immune system. So ultra processed foods do that. And if you're on a something like a Mediterranean diet, which is kind of in vogue right now, but basically a diet that doesn't have ultra processed foods, that's relatively plant based, it kind of corrects these things. It helps to build up that barrier again, that mucus layer, and prevent you from flaring. Now, the caveat to that is some people will say, "Oh, then why do I need medicine? I should just do a Mediterranean diet without." But I've seen it countless times, is that the best results are with both. The medicines do help, and it seems like most people need them. Even if you go on medicine and you, like, go off medicine and stay on something like a Mediterranean diet, the reality is most people flare, but not everyone, but most. And I would say it's the combination that really makes the difference. So yeah, we have good research now to suggest that probably most people who are diagnosed with Crohn's nowadays, it's not purely a genetic disease, but with some genetic predisposition, it's mainly these ultra processed foods, in my opinion, that are causing it. And I talk to patients all the time about their diet, and they say, "Oh, I eat a healthy diet. I'm not eating all this junk food." But is that really true? Were you really eating a healthy diet when you were like a kid? You weren't eating like the sugary cereals, the processed foods. So, and even things that people think are healthy, usually have some of these additives that I know you know so much about as well, about these carrageenan, polysorbates, maltodextrin, sodium caprate, titanium dioxide, all of these hidden ingredients that just jack up your gut. And if you're a genetically susceptible individual, even if you don't have any family history, there's over 200 genes associated with Crohn's and colitis. If you have one of these variants that probably gave you some advantage evolutionarily thousands of years ago, your ancestors, in fighting infections and fighting parasites that we don't encounter now because it's such a clean environment now.
Mm-hmm.
So if your immune system wants something to do and it has nothing to do, and then you dump these ultra processed foods into your gut and it messes up your gut lining and the mucus layer that protects it, it's a recipe for disaster. It's a recipe for IBD. And this is what infuriates me, is that we know this stuff, and doctors, and this is part of my field, which I do think there is some push for prevention now, but I think that this should be more of an active effort to tell people with Crohn's and colitis, and it should be an official recommendation to avoid ultra processed foods. Food should be labeled with, there is a classification system called the Nova classification. So Nova class 4 foods should be labeled. And I just tweeted this recently that I think it should be the same thing. Celiac disease doesn't eat, if a celiac patient doesn't eat gluten free, everything's labeled gluten free. There's restaurants that have that stuff labeled.
Mm-hmm.
There should be Nova Class 4 labels on food, and not just what you buy in the store, but in restaurants too. If they're using any of these ingredients in their food that I just mentioned, these emulsifiers, these preservatives, these things that we know harm the gut, it should be labeled, and people should stay away from these things.
I couldn't agree more. And just to give, for anyone who is newly diagnosed with IBD or is new to this world, that was a lot, you know what I mean, of information. And, it is our understanding, right now that, inflammatory bowel disease, Crohn's disease, ulcerative colitis, microscopic colitis, indeterminate colitis, they're not traditional autoimmune conditions in the sense that the immune system is not just randomly attacking healthy tissue of the gut. There's some sort of change in the microbiome. There's some sort of change in the integrity of the gut lining. And please correct me if anything has evolved or changed. But then we see a leakage of bacterial organisms, food particles, other constituents of the microbiome into this inner layer of cells, into the lamina propria where there's an immune response. Has anything changed in that mechanism, or did I get that right?
No, that's about right. I mean, I think overall that's the progression. Now, there is something called early onset inflammatory bowel disease, where kids are diagnosed as like babies, like as infants, and in that setting, I think it's more of a
Okay.
genetic predisposition, as opposed to, obviously they're not. It's too soon to blame it on processed foods, although. I actually just recently had a daughter. My daughter's 10 months now,
Oh,
and
congratulations. Wow.
oh,
Wow.
thank you. And you can imagine how careful I am with her as far as trying to optimize her microbiome, her microbiome. But but yeah, I was looking into these baby formulas,
Mm.
and it's crazy. The formulas that most people use, like Infamil, Similac, they have a lot of these ingredients that I just mentioned, and I'm like, what? Why are these in here? So you can, like, carrageenan, I believe, is there. Maltodextrin is there. So I think, yeah, again, a genetically susceptible individual, that putting that into your gut from like birth is, obviously breastfeeding is the optimal way to go, but realistically sometimes you have to supplement with with formula or have to use formula exclusively. It kind of depends on the situation. And the fact that those are the most affordable ones that most people are using is unfortunate. Now, they have other formulas that are way more expensive, unfortunately, that don't have those ingredients. Like we use one called Bobby's formula, but there's a lot of them like that that you could just find at Whole Foods or order online, but they're quite pricey. So, yeah, I know there's some effort to look into the formulas. I know Marty McCary through I know he's resigned now, but he was wanted to look at the formulas and kind of do a whole audit on like the ingredients on them. But yeah, no hard data on that these formulas actually trigger IBD or are responsible for IBD. I'm not implying that, but it is something that they should look into.
I mean, as a kid, I ate a lot of processed food. I mean, there was no, you know what I mean? There was just no question about it. You know what
For
I mean?
sure.
It's just we all did. And it is a shame. I mean, and there's things that are essentially given to IBD patients still, many by gastroenterologists, by the mainstream healthcare system, whether it's as simple as mesalamine, which still contains carboxymethylcellulose and titanium dioxide in it, or is something like Ensure Boost, which has a bunch of these additives in it.
Right. Yeah, that's also a conversation I have a lot with patients because I do implement exclusive enteral nutrition in my practice.
Mm-hmm.
In the motivated person who really wants to avoid using steroids for Crohn's disease,
Sure.
and it does come up like, oh, these shakes have like all these ingredients, like as you mentioned, maltodextrin, carrageenan. That's not going to be for my gut, but uh, I focus on outcomes rather than mechanisms. As like outcomes trump everything for me. So if I know that polymeric formulas do induce remission almost as well as steroids in adults when you use it for Crohn's, and it can take sometimes 6 to 8 weeks to do that. I don't worry about the micro ingredients that may theoretically be harmful, and realistically Ensure and Boost are the most affordable ones that are most easy to get. You just go to your Walgreens and it costs like $2 a bottle, so it's pretty affordable. Now, if you have the funds and you really want to go get formula that is has better ingredients overall, probably Kate Farms would be the way to go. But that
Still has seed oils in it though.
sure, is there a formula that
Well,
you've looked into that you think
well,
is
I
the
mean, there
best?
was that study out of Seattle Children's with a reverse engineered EEN. Right?
Sure.
There was that study. I mean, we do. I mean, I've never done like a fully. Well, we did have one member who actually did a reverse engineered EEN for himself, and he had good results with that. He ended up still taking Entyvio. Sadly, had a side effect to the Entyvio, which is a rare kidney, some kidney damage or something that was associated with it. But for me, I mean, I think that we could do so much better than if we educated patients really well. Like if I was to just give you some ingredients off the top of my head, I would say you could stick you know what I mean? You could stick a banana in there, you could stick a multivitamin in there, you could put certain whatever protein powder is tolerated. I mean, I think there is a way to actually do this in an inexpensive way with an educated patient as well to make their own. But of course, it's not it's not tested. You know what I mean? The Boost and Ensures and the one by Nestle or whatever, the Modulin or whatever. Those are the ones that are tested and studied. But I think as we move forward, we can educate IBD patients to and maybe it's not full EEN for them, but it is just sometimes that this is able to give their gut at least a break for some period of time.
Sure. Yeah, and the point about seed oils is I've done deep dives on seed oils too, and it's weird. It's like it's a difference between mechanism and outcomes. So I've looked into studies about particular seed oils like canola oil, for example, which when you look at the actual studies on objective measures of inflammation, like CRP, and I don't think this is really in the IBD literature, but in other fields, it doesn't seem to have an objective effect on objective parameters of inflammation. But on a theoretical basis, you'd think it's pro-inflammatory because of the whole, more omega-6 or arachidonic acid and like kind of leading to that pathway of more inflammation as opposed to omega-3. So I understand from a theoretical perspective why it would be a problem, but yeah, from my review of the literature, it doesn't seem like it actually in the real world makes it contributes to significant inflammation. Now you can critique those studies. Maybe they were too short term to see, the consequences of it, and question the outcome measures. So that's why I'm not so against seed oils if it's something that's in a product like EEN. Of course, when I tell people to, as far as dietary advice, though, I always say like the best thing to cook with is extra virgin olive oil. Overall, I think that has the best data as far as not just being health neutral, but having health benefits. I think seed oils overall so far is probably relatively health neutral. And then there are things that are definitely bad for you, like trans fats, if you really go by the evidence. But I understand the theoretical concern.
And just remember for anyone, do not cook at a high heat with a extra virgin olive oil because that's going to break down. But something like an avocado oil or ghee at a higher heat would probably be a healthier oil, in my opinion, if you're going to cook anything above medium heat.
I still use extra virgin olive oil and everything,
I I
but
I would not,
but
Samir. I
yeah.
would not. I would just advise you, in my opinion, anyone against cooking with extra virgin olive oil at a high heat. Like if you're cooking a steak at a in an iron skillet or something like that, use something that is stable right there because it does oxidize a little bit and break down. But I respect that. I for me personally, if I eat I'm in remission from Crohn's disease. I take, sometimes I'll take a little bit of mesalamine every now and then. I do notice a benefit from it. I probably just admittedly do use 5-10 milligrams of prednisone maybe every 6 months, or something like that. If I feel something, I use a little bit of budesonide at the same time if I need it. It's something that I've worked out, with my gastroenterologist. And normally if I do, remission for me, I don't describe as like absolute perfection. In there, I describe it as, hey, I may have eaten something that didn't work for me. I'm going to pare back my diet for me in a much more SCD like direction. And for anyone doesn't know that acronym, it's the specific carbohydrate diet. Essentially, we could just sum it up as saying no starches in your diet. And yeah, I tend to just my body sort of profoundly responds to it. I don't know if I'd call myself a super responder to diet like some people are, but I do respond. And if I eat a little bit of seed oils, for me, I do react to that, especially if something is cooked in seed oils. Like almost every, I ate some street food in Paraguay, and I just I knew that it was cooked in seed oils. I could feel it. It didn't feel that great, but for me, it's as simple as getting some exercise, eating some antioxidants. I could just eat a ton of blueberries or a ton of blackberries. You know what I mean? And that for me tends to counteract. Is it a total placebo with my scientific understanding that this is happening? I accept that it could be. I also accept that maybe the fiber and the polyphenols and the flavonoids that are found in blueberries and blackberries are contributing to it. That there's an antioxidant effect. I could take a little bit of extra vitamin C or something like that. But this is how I've managed my Crohn's disease. I've had continuous normal inflammatory markers. Admittedly, I haven't had a colonoscopy in a long time, in close collaboration with my GI doctor. But I think, what I mean, we are all different in how we react, and all of our diets, look different in this respect. Samir, what dietary pattern are you following these days?
Yeah, so some background on my diet is probably since very close to when I was diagnosed, maybe within a year or two, I started the specific carbohydrate diet. along with various medical therapies. But I was on that strictly. I mean, 100%, which I find the specific carbohydrate diet is probably the most difficult dietary protocol that exists because of the fanatic adherence that you have to follow with being 100% on it. There's no leeway on anything. So I did that for 7 years.
Wow.
And during that time, and I actually did it, I was in medical school when I started it. I went throughout residency off medicine and just being on that diet, which it was 3 years of internal medicine residency. And looking back on that time when I just managed it with diet, it it was probably the my least happy time
Mm,
if I have to really reflect on it. I mean, at the time I was like, yeah, I'm managing this with diet. I'm happy I'm not on medicine, but I wasn't perfect. And I everyone's different. I mean, even in my practice, I've seen people with different tolerances for symptoms. I've seen some people they could go 30 times to the bathroom a day, and they're just living like that. And I'm shocked when I see that, because I know I'm not like that. I want to feel perfect. Like, that's just I have a high bar for how I want to feel, and so that I can be able to work and just enjoy life. So
well, you can't be running to the bathroom in the middle of a scope, so that's
exactly,
really
exactly.
possible for you.
So those 3 years of residency, it was suboptimal. It was good enough. It was good enough for me to work, but I'd have intermittent issues, but I never had to take any time off. So in that way, I felt like the diet kind of kept me going for some time, but eventually I had to go back on medicine. So it was through that experience of being on the strict uh, specific carbohydrate diet and kind of being on and off medicine. And every time I was like, okay, I'm going to use this medicine and see how things go. And I did have some side effects to medications, like no doubt. So I had to stop them for various reasons. And and I did seem to do okay for some time, but inevitably it would come back to some degree, not to like a major degree, but to a degree that it was affecting my quality of life, and I had to go back on medicine. So that's why that initial study that I referenced, where I said, yeah, like the combination of medicine and diet is often kind of necessary, because I was on a pretty good diet, like.
Mhm.
There's some critiques on the specific carbohydrate diet, and that it may be somewhat meat heavy. It may be somewhat heavy on, dairy, as far as like the dry cured cottage cheese. And even the specific carbohydrate diet has no restriction on seed oils, by the way. You can
Amazing.
use
Yeah.
whatever oils you want besides soybean oil. I know there's some exceptions, but you can use canola oil, you can use vegetable oil. I mean, this is an old school diet. This diet's been around since the 1950s, used initially for celiac disease before we knew gluten was the cause of celiac. But then it kind of got later on adopted for IBD in certain kind of circles. So yeah, maybe it wasn't like necessarily as plant-based as it should be nowadays, when we look at the optimal diet, like a Mediterranean diet. But yeah, I was eating all organic, like absolutely to a T, and I would still eventually something would set it off. So now, what I eat now, I still eat probably 90% specific carbohydrate diet, but it's just because I'm used to it. And through that whole process of like elimination diet and figuring out what my system kind of tolerates and what doesn't, I I've kind of found foods that I tolerate outside the diet, and also foods that are allowed on the diet that I don't tolerate, that I've eliminated. So I'm basically specific carbohydrate diet. I don't eat the 24-hour yogurt. I never tolerated that well.
Mhm.
But there are foods outside the diet that I do eat, like potatoes. I do eat, and quite a bit of it, and I do fine with it. Fermented rice. There's certain Indian foods that are fermented rice, like idli or dosa. I eat that pretty often.
Yeah.
Um, but besides that, it's pretty close to the specific carbohydrate diet with those exceptions, and I'm still pretty strict about it. Another thing, I've implemented things over the years, just kind of tweaks that are not necessarily completely evidence based, but I'm kind of jumping the gun a little bit, but microplastics is something that I'm paying attention to. And so I used to drink water out of plastic water bottles all the time, but now I have a reverse osmosis filter. I drink water throughout the day through a like a metal stainless steel water bottle. And so that's something I've implemented. And exercise. That's another thing that I've really taken seriously when I would run occasionally here and there and do push-ups and stuff like that. But now it's kind of tapered down a little bit because I just had a daughter and that's taken a lot of my time.
Yeah.
But before I was going every other day. I would either run 6 miles
Wow.
outside or I would do weights. I'd do weight training, triceps, chest would be one day, back biceps would be another day, and then legs would be another day. And I was just consistently doing it. Um, so far, I think, I don't know if it's having like a direct effect on the IBD, probably to some degree, but I'm just trying to be healthy now. Like I've gone beyond, oh, like I'm just doing everything to target my Crohn's, because what I've seen is that it's all converging. Like there are these common things that promote good health, and those things naturally help the IBD. So
Mhm.
yeah, Mediterranean diet, exercise, good sleep, stress reduction, getting outside when you can, provided that you're not on medicine that increases your risk of skin cancer. That's the caveat. But I think some sun is good. Completely eliminating sun is probably not a good idea, but you got to be careful with certain medications that you're on.
Yeah, like 6MP and others.
Right.
Yeah, I mean, and just to say, you know what I mean, all of our diets are extraordinarily different. You know what I mean? For example, I don't have any issues with red meat. I could eat almost unlimited amounts of red meat for some reason. You know what I mean? And maybe that's because I've just been eating red meat for a long time. I don't know. I'm not going to make an argument about the overall health benefits or risk
Sure.
of eating red meat, but I can tell you that I can eat a fatty steak and there's absolutely no effect on my Crohn's disease. You know what I mean? Where, if I eat obviously processed foods, or if I feel something is cooked in seed oils, or if I'm eating too many starches, you know what I mean?
Yeah.
That I have a problem. But honestly, Samir, I want to, relate to people who are following, a really strict diet. And if that works for you and you're happy, I have many members who are much more strict on their diet than I am. And some of them are, very anti-medication and they're in remission, they're in remission, or they're close to it. You know what I mean? And I respect that. I am like you. I would be very unhappy if I had to be strict SCD all the time. That would be very, very difficult for me. I enjoy going out. I enjoy eating a wide diversity of different foods, of different meats, of vegetables, of different fruits, of different types of starches I can tolerate here. That in Paraguay, there's a lot of different tapioca gluten-free starches that I tolerate. I eat gluten very rarely. We have a little country house out in the jungle of Paraguay almost, and it's incredible that there's this little tiny pizzeria down a back alley where it's owned by an Italian family, and the son did a whole internship in Italy, and they use a sourdough, you know what I mean, to essentially cook it. And I can tolerate that pizza, but no more than, once a month or something like that. And for me, if I do react to a food or something like that, I have a protocol that I have in place that I can actually go back to. I go back to a much more simple diet that's a pretty strict SCD, just, high protein, high fruit, for some fermented foods in that way. And for me, I do take a lot of supplements and herbs, and I know you have some skepticism around supplements and herbs and all of that. The reason why I like supplements and herbs is they allow me to eat a much more wide diversity of foods and to sort of, and for me, I can take something like fish oil or quercetin or resveratrol or these things that have mild evidence in IBD, whether they're in animal models or there's been a small clinical trial or a small RCT or something like that. And I do respond. to those things. And so that's sort of where where I found, but anyone who does take these supplements and herbs, it's really important, in my opinion, to be very transparent with your medical team about what you're taking. That's something that we do here, and also to make sure your liver enzymes are checked and all of that.
No, totally. I mean, your own body is your own laboratory, and if you find something that works for you, I'm usually in support of that. Some nuances I have when I have people see me who are taking supplements is, yeah, you could take what you want, but we just have to make sure we're doing some blood work, monitoring your liver enzymes, because sometimes what is marketed to be in these supplements is not, or there's extra stuff in there. There can be some liver toxicity. So if you start any kind of new supplement, it's good to, after like a month or two, to check some liver enzymes just to make sure it's not causing any problems. um, and some nuance to some of the things we were talking before about. You mentioned red meat. You seem to tolerate that very well. And for me, I don't eat any red meat because I don't. So everyone's different. But and there's also this, just something I want to emphasize to your listeners, is that symptoms don't always mean it's the Crohn's that's acting up. Like if you eat a food and you get diarrhea or bloating or whatever, um, it's not always that, oh, it's like my Crohn's that's flaring. It's probably one of the most common misconceptions that patients have when I see them in the office about when they have questions about diet. It's like, oh, I'll talk about something like a Mediterranean diet, and they'll be like, oh, all of those foods like flare up my Crohn's. And, is it really flaring, or is it just that you've avoided these foods for a long time? And maybe if you slowly reintroduce them, now that you're in remission on the medication, you'll tolerate them better. So
Mm-hmm.
that's one nuance. Now, as far as and I've said this before about all these like herbal therapies, my attitude comes from the perspective of trying many in the past and being very kind of objective and scientific on if it was having an effect on me. And I tried many, and I've looked at studies and tried supplements based on low quality studies or mouse models or mechanistic principles. Still have a whole drawer full of these old bottles of things that I tried that ultimately didn't work. But what I can say is the one herbal preparation that I've actually had good results with, in actually both myself, I've tried it, and other people, is CurQD. Um, and I don't know if you've had clients on your end who've tried it, but my goodness, I did not. I was very skeptical of it from the beginning. You can look back at my tweets from a few years ago because of the side effect profile of King Dye, one of the components of CurQD. King Dye is indigo powder. It's been associated, rarely with like really long-term use. There's case reports of it causing pulmonary hypertension, which is a serious issue. The artery that goes from the heart to your lungs can get tight, but it's supposed to be reversible with stopping it. And also, it can cause liver issues, elevate the liver enzymes, and also lead to intussusception, the bowel or the colon telescoping on itself. Sometimes people would need surgery for that. So, because of that side effect profile, I was a little bit wary of it, until I tried it myself once, and I noticed a significant difference. And then I actually started using it in my patients, because there is a randomized controlled trial showing that not only do people with ulcerative colitis potentially can feel better with using it by itself or in conjunction with either anti-TNFs or Entyvio, it also, there was evidence that it can lead to mucosal healing and actually healing of the bowel. So I started using it, and what shocked me is I have had maybe 3 or 4 patients now who failed everything, like almost every medicine for their ulcerative colitis, and ultimately CurQD worked. Like we're talking like powerful biologics, JAK inhibitors. I mean, and they'd been through the whole thing and were facing surgery. And I have 2 patients in particular. One who eventually we used Stelara or ustekinumab in conjunction with the CurQD, and the Stelara by itself was like partially working and to a minor degree. Then I added CurQD on it, and miraculously she's in remission now, and we're crossing our fingers. The other person had been on everything too, even cyclosporin in the hospital to induce remission, which is one of the biggest guns, and was facing surgery too. And then yeah, Stellara, and I used cyclosporin and transition to Stellara. That it wasn't cutting it by itself. I added CurQD, mucosal healing on colonoscopy, and then he stopped Stellara on his own. He's just on CurQD and he's doing
Mhm.
fine so far. So I mean I've seen. Oh, sorry. Is this okay? So I've seen some pretty miraculous things. I've also seen it not work too. I've seen it not work at all. So it's just variable. It's a different mechanism of action. So
I've also
yeah,
seen some significant side effects from the King Dye component, and that is one supplement I haven't tried. I consider myself a guinea pig for my clients in many ways because I'm just doing so well. I'll just try everything, you know what I mean, to
sure.
see how it's going. King Dye is just one I have looked at the side effect profile of it, and I'm a little bit scared. That's just one thing I'm not willing to just put in me because I'm just doing so well right now. And on the
Right.
other hand, I have also seen some really, really good results. And I do wonder how much of it is actually the King Dye and how much of it is just the curcumin that's in there, which we use all the time, you know.
Yeah, I personally think it's mainly the King Dye. I think of King
Wow.
Dye as kind of like prednisone, like a different form. It doesn't have the same side effect profile. It's a different one. It's overall likely, probably overall a safer thing. But even the CurQD protocol, it tapers off the King Dye over time. It has like different bottles you get depending on your symptoms, and eventually you just end up on curcumin. The problem is though, a lot of people flare once they get just on curcumin, is what I've seen, and then they kind of have to go back to the some degree of using CurQD. But it seems CurQD seems to be okay to use as long as you're using it in a pulsed fashion. Like you kind of go higher dose, lower dose, and then off of it for some time, and then if you need to go back on it, that seems to be fine. And apparently, this company, Eva Nature, that makes CurkyD, who I have no financial, by the way, I have no financial ties to anybody, to them, to any pharmaceutical companies. The farm reps keep coming to my office and invite me to dinners and all this stuff. I say no. Anything they tell me, I say email me the article or tell me what article to read. I don't take anything they say at face value. And they know that now. They stopped inviting me to anything, anything, but they still try to meet with me and stuff. But I tell them, hey, I want to be completely objective. I don't want any, and I give them a lot of pushback. Sometimes they do meet me in my office and I talk to them, and I sometimes really go at them because, yeah, I don't believe in being compromised in any way when I'm making decisions with patients. But in any case, yeah, CurQD I still use. I like it. The way I use it is if someone's on mesalamine for ulcerative colitis and they're about to go to a biologic, I'll sometimes use that, or I'll use it as an add-on to an existing biologic, particularly anti-TNF and Entyvio, before jumping to something else. It is pricey though. It's about 100 and something like $150 for 6 week supply, and you have to, and it's not covered by insurance, so it's pretty pricey, and it's not realistic for some people. But it is something to consider. Now there is a different form of it where you just get pure King Dye on Amazon through this brand called Treasure of the East. And in cases where people can't afford the
Heavy
the
nature.
QD, yeah, I'll tell them to use that. But these are cases where people are like facing surgery, and I'm weighing the risks of, they're getting it from a company in China that may not be as vetted as Evan Nature.
Hmm.
But it's weighing that, and that's one of the patients I'm talking about. She's taking that and doing well with it versus getting surgery. Another point I wanted to bring up, if you don't mind,
Oh.
is the whole thing about surgery for ulcerative colitis.
Hmm.
Now, I may get some heat for saying this, but I think that if the solution to a problem requires a whole subspecialty to deal with that solution, I don't think it's a great solution. So what I'm referencing is J pouch surgeries. Okay,
Mm-hmm.
there are IBD specialists who specialize in pouch disorders. Like that's a whole subspecialty talking about people. And just for the listeners who are not familiar with what I'm talking about, is when you have ulcerative colitis and it's resistant to all the therapies, and the only option we have is surgery. You pretty much have two options. They can either take out the colon and you have an ostomy, an ileostomy, or they make a pseudo rectum out of the small bowel called a J pouch. So then you're all reconnected and you still have bowel movements through your rectum, but the through your anal sphincter and the small amount of rectum that's left. But they make a rectal reservoir out of the small bowel. But yeah, the stats, in my opinion, aren't great. Like with that, with the J pouch, you can still sometimes expect to have up to, I've seen people have as little as 3 to 4 bowel movements a day, but it can go up to 10 bowel movements a day, and that's considered normal. You're supposed to have control over it and there's no bleeding, but still, that's like a lot of trips to the bathroom. And you also are expected to have one bowel movement overnight. That's considered normal. And then on top of what is considered normal, the majority of people get pouchitis eventually.
Yeah.
Now, most of the time that's treatable with antibiotics, but now you're talking about putting antibiotics in your system
Mm-hmm.
over and over again for pouchitis potentially.
Mm-hmm.
And then, there's a certain small percentage of people with J pouches who need to be on biologics again because they develop either antibiotic refractory pouchitis where the antibiotics don't work, or they develop Crohn's disease, which they thought was ulcerative colitis initially, and then they're on biologics again. And they have a whole subspecialty of people that just deal with pouches.
Mm-hmm.
So I mean, I know that's like what we have now, and a lot of people, because they don't want an ostomy, they're really resistant to that. They're more open to the J pouch, but these J pouches have a lot of problems, and over the years I've seen a lot of problems with them.
Yeah.
But yeah, I know for younger people.
Controversial opinion in many ways, but you know what I mean. I would say personally,
you and I have Crohn's disease, so we can't necessarily speak for someone with ulcerative colitis. But personally, if it was me and I had ulcerative colitis and I did need a colectomy to survive, and it was a life or death situation, I would choose the bag. That's just me. I've seen so many problems with
Me too.
pouches. Yeah.
Me too. I would do the ileostomy, and the ileostomy is not without problems. It's definitely something you got to get used to, and you can get hernias, peristomal hernias from it. But overall, it seems to be I mean, if your goal is really to get like a good quality of life again, um, I don't. I think the ileostomy is a probably a better way towards that compared to a J pouch. But I think for cosmetic reasons, and definitely when you're young, there's this kind of like social stigma to the ileostomy bag. But um, and I understand that. I'm sympathetic to that. And you can always change over to an ileostomy eventually if you do have problems. But yeah, there's problems with the J pouch.
And yeah, and I mean, there's actually like whole companies that are like have sport bags and stuff. Like I follow this one guy who's a huge surfer. You know what I mean? He surfs with his bag all the time, and he's, you know what I mean, okay, in that respect. Yeah, I mean, you know what I mean. This is a very very tough condition, and I do want to just sort of piggyback on one thing that you did say. I have many clients. I'm not going to say the exact number right here, but more than fits on one hand of, that have come in on every single medication. They've come on huge amounts of Remicade, prednisone, and everything. And where they are right now is off medication in both clinical and endoscopic remission right now by changing their diet, by adding this specific supplements and herbs, not necessarily on King Dye. You know what I mean? Right there. So for some individuals, this is possible. One girl came into our program quite a few years ago, maximum dose of prednisone, maximum dose of Remicade. Nothing was working, 20 bowel movements a day. She used to pretend that she lost her prednisone to take 60 milligrams rather than 40 milligrams, that was like what she was doing to just cope with all of this. Changed her lifestyle, diet, 6 months of intensive work of ups and downs together. She has now been in remission for 6 years, you know what I mean, since this. So it's like, is that just like a coincidence? You know what I mean? I think it's more than a coincidence, and it does show that there is a tremendous lifestyle component to this condition. And that doesn't mean, I would say over a little over 50% of my members need a biologic, need an immunosuppressive drug in addition to all of the lifestyle interventions. I would agree. But I would say almost half the members in our program right now are able to do this with diet and lifestyle, supplements and herbs, stress reduction, and all of that. And we can, go on a long tangent here about changing environments and stress reduction and, all of that type of stuff. But this, I think, just to piggyback again on what you said in the beginning, there is more to this disease than just suppressing the immune system, which is critical in the beginning. You have to do it. You have to stop the inflammation. You have to put out the fire before you can actually have healing that occurs.
Sure. No, definitely. That is for sure true. Now, the what you mentioned about people who are maintaining remission, potentially off medication, I can speak from my perspective, is that well, number one, like from the start of and I've been in practice now for almost 10 years. I think it's been 8 or 9 years now. And from the beginning, given my background and what I've gone through, I wanted to be somebody who recommended dietary therapy from the beginning. And I've been doing that to everyone I see, new diagnoses, second opinions. It's just from the beginning, this is optimal. I used to say it's kind of like extra credit. It's going to help you probably maintain your remission better if you do that. And I would say overall, most people, it's very rare that people like go full in with changing their diet like completely. Most of the time they try to make better choices overall, but still, waver from something like a Mediterranean diet or one of these other therapeutic diets a little bit. And that's still probably helpful to some degree. I do have a handful of people in my practice, probably 4 or 5, that are okay. They had IBD like years ago, probably 10, 15, maybe 20 years ago. And to the point where some of them, were on prednisone, were on biologics. And I was pretty confident they actually had IBD. It wasn't something else. It wasn't like an infection or something called ischemic colitis or, some other thing. They had biopsies that were consistent with having IBD. And then they saw some of them, my partners in my group who saw them like years ago, kind of dropped off the radar. And then they see me like years later for the first time, and I go over their records, and they're not taking any medicines, and they feel fine, and they're not eating anything different. They're eating like a Western diet, like completely whatever they want. So, and then I scope them just because, for colon cancer screening, they need to get scopes, more frequently than for someone without IBD. And for these people, I see like a bunch of pseudopolyps in their colon, which are pseudopolyps are not precancerous polyps. They're just signs of old inflammation, kind of almost like a little bit of scarring in areas where inflammation was, but no active inflammation. Biopsy's normal. So I do think there is actually like the people in my practice who are actually not on medicine are like these kind of people, which I don't know if their IBD just kind of burned out and it's just gone. And some of these people are really sick to the point where, and some of them just dropped off the radar and just said, hey, like, I just don't want it to be on medicine. I'm just going to keep going. And it just burns itself out. Now, is that typical or usual? No. Is that something I recommend for people? No, because I see the other end of that more often where people kind of ignore their disease or just try to power through it and they end up needing surgery or having even cancer in the colon. I've had many cases of that. But yeah, that's just kind of one of the things I've observed is there are people in remission off medicine with mucosal healing who I can't explain why, but it just kind of burns itself out. And I have another, one of my podcasts I did years ago with someone who had definite Crohn's colitis, who it just went away with like lifestyle stuff. He didn't change his diet. He went deeply into meditation, changed his work environment. It's a pretty popular podcast on my channel because I did a real, very detailed, almost like case report on him, going over his records and seeing what he did. And to this day, as an update, he's still in remission off medicine, and He's a hardcore meditator. He meditates like several hours a day. That's what he does. So it's possible. These sporadic cases of spontaneous remission, we call it spontaneous, but there's probably things that are responsible for it that you can go into remission without meds. And there's not a lot of people in my field who are willing to say that or really believe that. But I do believe it happens. It's rare. I tried to do it myself and was not able to. So you shouldn't feel disappointed if you're one of these people who needs medicines. Yeah, that's another thing is sometimes people view medicines as like defeat, like, oh, like I gave in to like the easy way. And
No.
but you got to use every tool that's there for you. You got to focus on quality of life. You only have a limited amount of time on this planet.
Mhm.
And if IBD is distracting you to the point where you can't live a full life, you just got to do what you got to do to get there.
I totally 100% agree. And I think these people should be studied. And I just want to give the perspective that I do not consider myself a spontaneous, healing case. I was faced with, they wanted to do an ileal resection on me. If you want to hear my whole story of how I healed my fistula through Ayurvedic surgical technique that we performed, you can listen to the podcast we had 5 years ago, by the way, still fistula free. After all of this time, my Crohn's requires constant tending. It does. Like it's not a spontaneous. I'm off meds, but it requires. It's like I'm so used to doing it, and I have so much freedom right now. But I can't just go eat pizza every day. I can't do that. You know what I mean? And if I was to do that, I guarantee you, I would have diarrhea. I would have fevers. I would have cramp. I would feel a little golf ball sized lump in my lower right side, right where my terminal ileum is, right there. And I eat so many different things because I travel the world and I'm a huge foodie. I just love food. I love eating all of these different things that sometimes that happens to me. And I'm going to share a very controversial opinion. And I want to just share this with people, and I don't think that you are going to agree with me on this one. And I also want to preface to say that this is not evidence-based, that this is not based in science, and this does not work for everyone. But in my mind, I think that prednisone is one of the most powerful tools we have in IBD. I think that even budesonide is one of the most powerful tools that we have in IBD, and that it's used incorrectly. I don't think people should be put on these huge tapers where they are, just on it for weeks and weeks and weeks on end. I think that it's better used in a sporadic type of way where you might give 20, 30 milligrams for like a week or something like that, and then take a few days off, then do another week of it in that way. Sometimes I've never recommended this to a member, but I have shared that experience, and I've seen many members who are either like steroid dependent or they just can't get their flare under control with medicine, with everything. And there's the combination of a sporadic use of lower dose prednisone and budesonide often. It's amazing, like what it actually happens. And there's never going to be a study, with this, you know what I mean? There's never going to be funding to study something like this unless the pharmaceutical companies invent some sort of mechanism. But, like Dr. Ali Arjamand, he no longer works in the IBD field. You might know who he is. He's a PhD nutritionist.
Yeah. Mm-hmm.
His view personally on prednisone, and again, he's not a gastroenterologist, he's not a doctor, he's a PhD nutritionist with Crohn's disease, is prednisone is very important for him too. He feels that it performs a kind of overall reset, and he takes it every 3 to 6 months, and just he makes sure that he does that because he believes that it provides sort of a larger reset for the immune system in many respects. So that's just one. I do think that we have tools like this, and I do wonder, you said this, like I wonder if King Dye could be used in this place instead of prednisone like this. And I personally wonder if other medicines like something like Rinvoq or something like that, where people are not responding to prednisone, could be used in a shorter period, and then people can go off and then just focus on their microbiome. There was a lot in that, and I'll let you respond.
Sure. So what I've observed with prednisone is, people have variable responses to it. But what you're kind of advocating for, which is this kind of intermittent, kind of short course use is, sometimes that can work and people respond very quickly to it. But I would say I see lots of people who we do need to give it at least 2 weeks to even start working,
Definitely.
especially the severe cases. And then, yeah, it becomes this race to get them off of it by like getting them on some other steroid sparing therapy so that we can taper it off. But yeah, there's a lot of, I actually went to the Advances in IBD meeting in Orlando, which was just this year or last year. Um, and they had a whole lecture about kind of budesonide and prednisone and about how harmful it is to take intermittent, even short courses of prednisone, because of the cumulative effect has been studied of short courses of prednisone in its effect on risk of osteoporosis.
Right.
And they were really harping on that because I think some people get reassured by, oh, if I just take like multiple short courses, it's less likely to lead to osteoporosis rather than these like long, huge courses of it. And they did studies looking at the cumulative effect of short courses of steroids, and there is a risk. But I hear what you're saying. Like the guy who trained me, Dr. Stephen Hanauer, where I did my IBD fellowship at Northwestern with him, he acknowledged that for some people, especially very resistant cases, we don't think of prednisone as like a maintenance therapy, but for some people, realistically, it is. You mentioned budesonide or prednisone. Some people are just left on low doses of prednisone, especially people who have developed adrenal insufficiency. If they've been on it for a long time, then they kind of have to stay on it. So, and there were patients that I saw in his practice who were just like on like very low doses of prednisone just because they couldn't get off of it. So in reality, there are people who take it for that purpose, but what we know about prednisone is it's not good as the other therapies as far as leading to mucosal healing. Often it doesn't. Budesonide, there's some data that it can lead to some degree of mucosal healing, but the other therapies are better. Now, Rinvoq is, I do believe, overall a safer agent to use for instead of prednisone for short-term use.
Wow.
And we do use it long term, but I think in short term, overall the side effect profiles, it's probably better. And people I use it like that too. Sometimes I'll use it as an induction agent, as a transition to another biologic.
Yeah.
And there's this whole other frontier of IBD that a lot of us that are seeing a lot of these patients are getting into now, which is using combined advanced therapies, which, the infection risk associated with it is there, but, the alternative is, are you going to do a colectomy, or are you going to be willing to accept some small increased risk of infection with, for example, adding Rinvoq to your Entyvio, or adding a big trial came out combining Tremfya and Simponi, or
Yeah.
Gasilcamab and Golimumab as a combination therapy, and they had some good results there. So, that's a whole other conversation. But yeah, I mean, that King Dye as an induction agent, I use that too, for sure.
Wow. Well, I've seen I have a few members who are on combo therapy with Entyvio who are getting pretty good results, and Entyvio is not that traditional immunosuppressive mechanism right there. So it is super interesting. I want to just say, just to continue one little thing about the steroids, I'm going to harp on GI doctors just real quick. Something that just
Please do.
nuts. Something that
Okay.
drives me nuts is the amount of people that come in with left-sided colitis or ulcerative colitis who are prescribed Endocort, or
Sure.
essentially, and
Yes.
it drives me insane. Like, people come in with proctitis and they're given
Right.
like Endocort. And for those of you who don't know, generic Endocort is released in the terminal ileum, and there's another medicine that's a little harder to get approved called Uceris, or generic Uceris, which was actually released in the colon. And I'd say I've literally probably advocated 20 times for this. And sometimes the GI doctors are like, no, sorry, I'm not willing to write a prior authorization to get the right, medicine. So I just wanted to put that out there.
So this is what's going on, and I've observed this. is that a lot of GI practices, uh, because IBD has become so complicated, like the medications, how they're positioned, there's always new ones coming out, and all of these different preparations, especially the new, like we have a GI fellowship program in our hospital, and the fellows, that's like the trainees who are kind of learning GI and eventually will be practicing. The amount of information that they have to know it's the most difficult topic within GI for them to pick up. Like everything else is but when they have an IBD patient, I've become like the go-to person for anybody in our in the hospital. Like if anybody is an IBD patient, get my opinion on what to do. But I think part of the reason it comes with such ease to me is because I lived it. You know, like I was diagnosed in 2006 or sorry 2008, when the only biologic available around that time was Remicade and Humira. And so I rode this wave, and I had a particular interest in it because I was making these decisions myself. So I rode the wave and saw, and you know, the people, obviously I'm relatively young, there's people that the people like my people who trained me, you know, who were doing this since like the 70s and 80s, and they really were there from the beginning. But at least I was there from the beginning of the biologic age and seeing like all of these approved, and to get that nuance to like how we evolved to where we are now, it's very difficult for trainees coming out now to really comprehend that. And also, even in GI practices, there's usually like one person who does most of the IBD and everybody else just kind of gives up on it. So that's why I think it's important to see somebody who specializes in IBD, if you have IBD, if possible. I know it's not always possible, but to get these nuances, like how drugs are released, what's the appropriate drug for you. But totally, you know, I see it all the time too. Anticort being prescribed for ulcerative colitis inappropriately.
And just to finish our conversation about meds, and then we could just go into maybe a more global topic as we wrap up. But it does seem like, you know, what medications are you using, you know what I mean, right now for your patients? Because it does seem like, you know, for example, in 2022, when we went to the Crohn's and Colitis Congress, or 2021, they were all about Entyvio, and then it seemed like they were all about Rinvoq, and now every new member is on Tremfya. It seems like there's always this new thing. So which medicines are you leaning towards right now?
Sure. So it all depends on that where you're at. Like there's a lot of nuance. It's like depends on what prior medicines you were on, what the scope looks like, how severe the inflammation is, what extraintestinal manifestations you have. Do you just have IBD symptoms, or do you also have joint pains? Do you have psoriasis? Do you have eczema? Do you have other diseases of immune dysregulation that, you know, because some of the meds can address not just the IBD, but other immune problems. So that's kind of but just generally speaking, ulcerative colitis, mild to moderate, I still use mesalamine if it works. If it doesn't work, then if it's still kind of mild to moderate, I'll use either Entyvio or Velsipity, which is a nice oral option that's, you know, relatively safe. And then, but if I have a severe ulcerative colitis patient where they have like what's called Mayo-3 inflammation, where they're, you know, they have ulcers in their colon or spontaneous bleeding, it just looks really bad in there, I'll go up front with usually anti-TNF, you know, infliximab, of which there are multiple forms of it now, plus azathioprine, the combination, and eventually get them off azathioprine, hopefully within 6 to 12 months, so they're just on infliximab. I also use Rinvoq, and now you can use it up front too, so it kind of depends on if somebody really prefers an oral option. We can use Rinvoq for some of the severe cases. Now, as far as Crohn's disease, first line therapy, I don't use mesalamine usually for Crohn's, especially if it's small bowel Crohn's. But if it's colonic Crohn's and it's relatively mild and it like kind of looks very superficial inflammation, I'll use mesalamine. But most of the time, because the data suggests mesalamine is usually not that effective for Crohn's, not better than placebo, especially with small bowel involvement, I'll use these IL-23 inhibitors tend to have very good efficacy data as well as safety data, to the point that that mechanism of action seems to even in some analyses be even safer than Entyvio with respect to risk of serious infections and other complications and side effects. So I am using that more. And as far as using Tremfya versus Skyrizi, Tremfya, I've traditionally have been more patients on Skyrizi just because that came out earlier. But Tremfya is a nice option that you can just do all injections. You don't have to do the induction infusions. But I consider them pretty much equivalent. It's kind of flip a coin, whichever one you want.
Okay.
Yeah, but if somebody has Crohn's with fistulas or
Mhm.
deep ulcers, I'll go straight to combination therapy with Remicade or infliximab like medicines plus azathioprine.
Okay. Well, ladies and gentlemen, this is how you want your GI doctor to sound, because the amount of clients that I get where they're just literally handed a list of medications, said, you do your research and you decide which
Right.
medicine you want to go on, which is fine in that way. But I just I want to move in the respect towards not only really educated IBD specialists, you're talking, who understand diet and lifestyle, that these are critical components to this, but that understand that there are different use cases for these medicines, and to be able to educate patients on this. And I'll just speak. I think the future of all care for chronic conditions is in a very educated patient population. I'm not a doctor, but, Samir, I spend a lot of time educating patients on basic biology, on just how their body is working. And I think that is just a huge missing component in how I meet young patients all the time who have parents who are working class. For example, we have a nonprofit as well, where we're able to fund some of these individuals to come into our program who can't afford it normally. And these kids are super smart, and they eat it all up, and it's the first time. And sometimes the actual difference between someone achieving remission and not achieving remission, or having progress and not, is just an understanding of how these medicines work, why diet is important, that there's a multi-step process to this. In our program, we work to stop and control inflammation. We let the GI doctors do that with either the prednisone or the biologics if needed. All cases, I don't think biologics are needed in every case, and I don't necessarily think prednisone is needed in every case. In my opinion, there is a role for certain herbs and supplements that have evidence behind them that can control inflammation. We then work to modulate and nourish the microbiome. I think one evolution in my thought is, when we talked 5 years ago, I was very against anything that took down inflammatory microbes. I was super against antimicrobial herbs, and I'm still pretty skeptical in those ways. Some of these things are very powerful, like wild oil of oregano and these different things. I think be very careful with those things, because you're messing with the microbiome right there. But I think in some cases where people are not responding to prednisone or not responding to biologics, there is a role for modulation of the microbiome in the terms of using antimicrobial herbs and or rifaximin from your GI physician. Then we work to nourish the microbiome through immense amounts of fruits and pureed vegetables and prebiotics. And in some cases, once people stop flaring so much, the use of certain evidence-based probiotics, whether it's just sort of a more normal strain that you can get through probiotic foods. Some people do really benefit from that SCD yogurt. I do benefit. I don't make it that often, but if I had someone making it for me, I'd eat it all the time. Samir, you did not benefit from that. Or there's that other probiotic, like Akkermansia muciniphila, that's out, that's shown, directly reduced in ulcerative colitis. I've seen some success with that. And then by accomplishing that first and second step, stop and control inflammation, modulate and nourish the microbiome, you can then repair and maintain, in my opinion, that barrier. And just like you said in the very beginning with that study, it's not enough to just control inflammation, because that barrier still might be leaky. So it's a whole system. And I think the future is in patient education, understanding this process. By educating patients here, and by sort of slowly, when I talk to a new member, I say, your experience at Systema or working with us is going to be like learning a new language in a little bit of ways. You're going to learn some language of biology depending on your experience here. I do teach people sometimes that the world of biology is made from carbon. You know what I mean? Just like these simple facts of chemistry that they don't know. And I find that that's often a defining factor. And I think I still do not know any other coach or any other program that has such a focus on education. Obviously not when someone's in like an acute flare, you know what I mean? We're not gonna, do that. But once they get to a stable point, that mindset, I believe, and just like you talked about, that being able to visualize, to meditate, to change their environment is sometimes the entire key. And our vision at Systema, and in this modality that I now call systems-based health coaching, is to address every part, Samir, of a patient's life. You know what I mean? We look at their work situation. I ask them, I do have degrees in neuroscience and psychology, and I'm not a psychotherapist by any means. I do not do therapy with people, but we look at their work-life balance. We look at if they are meditating. I often notice that members do better in warm climates, for example. We've had members move temporarily to warmer climates, and they just do better in that area. And then in addition to all of this, it's this collaboration that is needed between people like me and patients, and between the medical and healthcare system. And we have something called the Remission Master Plan, where they type up this document, essentially with their whole protocol in it. And when we talked 5 years ago, there was no AI or anything like that. And it would take like a month for us to help them and type this up, and we'd have to use templates, and it was really slow. And now we just have a Claude project that they use, that they come into our program, they use a Claude project, they put in everything that they're doing, because think about how many patients you see that they just forget what they're taking. You know what I mean? They don't remember the doses. They don't remember what brand they're taking. It's all sorts of stuff. We get that all clear, and then we try and deliver it to you as GIs on a silver platter. You know what I mean? That's summed up. The studies are there, their doses are there, and then you can look through it and be like, oh, no, I don't want you on that one, or that makes me uncomfortable, or I'm going to be sure to make sure that your liver enzymes are checked. So that's what my vision is in many ways for the future of care. You know what I mean? Right there, where there is this synergy between patient empowerment, education, where they are sort of masters of their own IBD, where they're these IBD Jedi, and we can call this podcast the Return of the IBD Jedi, as I was saying before. So sure. That's why I've been somewhat technical with Samir in this, and admittedly I do have a science degree and I did attend some medical school, but this is the reason why I left medicine, was to build this system right here, to change how patients are educated, and to try and synergize this world of lifestyle and medicine together.
Perfect, man. I'm excited to see where you go with this. And yeah, maybe there's some patients that I'll see in the future that'll bring me their IBD master plan. And I'd be curious to see how it looks. So
yeah,
great.
Beautiful. So just as we wrap up here, Samir, what would you say to just someone who's in the middle of it right now, who's just really struggling, and they've just they've tried everything, and it's not going the way they want?
Sure. So, and I think this will be my last thought. But we definitely should do more of these. I'd be down for maybe a part 4 if you're down. But what I would say, what I would say is, you're not alone, and you're always going to be the best advocate for yourself. And so the more that it's a delicate balance. You can go into really deep dives and try to do everything you can to to improve your situation, which is encouraged, but sometimes you can go overboard. So I would just say I like to keep things simple. I think there's a lot of noise out there. There's a lot of things you can try and, look into. And over the years, I've seen people do some pretty crazy things like, do hookworm therapy or do water fasts or, do things that are kind of really outside the box that sometimes can be dangerous. So what I would say is to start with, find an IBD, find a GI who you get along with, who is specialized in IBD preferably, so they're all up to date on the medications, and take their advice. Whatever medicine they think is right for you, I know a lot of people get hung up on, oh, am I going to be on this forever? Not necessarily. And actually, in reality, most of the time it isn't forever. For one reason or another, sometimes it needs to be stopped or changed or whatever. But just go on whatever medicine the GI says is most appropriate for your case. But that's not the end of the story. Now you have to take some of the onus on yourself as far as doing things just to overall be healthy, and that's going to help your IBD. Follow a good diet, exercise, stay socially connected, reduce stress, get outside if you can. And that's it. Start with that. Start with that. And then, from there, if that's not working out for you, then it may be time to look into some other options. But that's like the starting point. Just start with the basics. Get on the medicine, and you'd be surprised how many people do well with that. And the last thing I'll say, one of the most important things, and it's been supported by evidence, there was a big trial called the Profile trial that came out that showed the importance of starting medication sooner rather than later. Now, I think a lot of people are terrified of these medicines, but in reality, the sooner you start them, instead of kicking the can down the road and doing it, a few years after being diagnosed, if you're started on the right medicine within, preferably very quickly after being diagnosed, it's way more likely to work. We're talking remission rates of 80, close to 80%, as opposed to if you wait several years, then we're talking it plummets. It goes down to like 30-40% remission rates. So look at the Profile trial that went over all of that, particularly that has to do with Crohn's and anti-TNFs, but probably applies to the other medicines. But yeah, that would be my suggestions, and try not to worry. You'll be okay.
You're going to be okay. And I would just say that healing is possible. The body has profound mechanisms and is always trying to move back to a state of homeostasis. And there are doctors, there are GIs guys out there like Samir, and there are people like me out there. And we welcome any of you to contact us. So Samir, thank you so much for your time. Just as a note, Samir does not endorse any part of anything I said. None of this was medical advice. Please always consult your GI doctor. And everyone have a wonderful day or evening. And there'll be a part 4 at some point. Okay?
Okay, appreciate it. Thank you, Andrew.